Good evening. We are now speaking about the circumstance of the diagnosis of Chiari malformation type 1. As you know, the diagnosis may be difficult, especially in children. And in this picture on the right, you see it's part of an exhibition of the Körperwelten, where you see this beautiful Chiari malformation. And in fact, we will never know if the anatomic subject was dead because of the Chiari or if it was a chance finding. So this is the ambiguity of finding of a Chiari. So there are many uncertainties with the clinical diagnosis of Chiari malformation. It is a common finding. It is the reason of many emergency consultation, mostly to reassure the patients, but in some cases with a legitimate concern. There are three main pitfalls. It could be overdiagnosed, because it's an incidentalloma. The patient may have migraine, which has nothing to do with the Chiari, and we may be induced to propose surgery whereas it was not indicated. It can be, on the opposite, underdiagnosed, because the child is nonverbal. He appears to be perfectly well, but in fact he's in pain, and we can see only after surgery that he is much better. And also we can ignore an underlying condition like hydrocephalus, bony malformation of the craniovertebral junction, craniosynostosis. So we have to be careful to do the right diagnosis at the right in the right patient. Besides that, we have also true emergency presentations with a rapidly increasing pain, with sleep apneas, and acute respiratory presentation. This is an example of a 12-year-old female which has who had acute onset of neck pain, sleep deprivation, and she underwent prompt decompression within a week or two after the diagnosis, and she was very much improved after surgery. You can even have patients presenting with a collapse, with a malaise, or even a sudden death. This is a near-death experience in a 9-year male who had the antecedent of birth hemorrhage and prematurity, and he had an acute respiratory distress. He was intubated. He had a refractory pulmonary disease requiring prone position ventilation, and in fact he was found to have a central hypoventilation, and MRI found Chiari with syringomyelia, and obviously all his presentation was related with symptoms of syringobulbia. And here you see how he was trying to swallow his saliva, and how he has amyotrophia on the myoclonus of the tongue. We have to understand that the respiratory disturbance in Chiari is a vicious circle, because you have a tonsillar herniation, which causes compression of the medulla oblongata, causing central apnea, which causes hypercarbia, causing cerebral vasodilatation, hence supratentorial herniation. So this is a vicious circle which can be aggravated during the rapid eye movement sleep, the period when you dream. The supratentorial hypertension can be aggravated by craniosynostosis or hydrocephalus. The tonsillar herniation can be aggravated by lumbar puncture, and the compression can be aggravated by bony malformation. So this is a vicious circle, and it can also, with airway obstruction, can aggravate the central apnea. So this can lead to a vicious circle which can cause the death of a patient, and it is we have regularly publication in the literature reporting Chiari manifested by sudden death. Then the lumbar puncture can be an aggravating factor. I have seen a few examples. This is one almost adult who had sequelae of infantile meningitis. He had a neurological degradation and fever. He underwent a lumbar puncture. Then he became erective, except for vertical oculocephalic reflex. I operated him on emergency, and he hopefully recovered slowly. This is another case of a 9-year-old girl who had a pain in the right arm. She had vomiting, then tetraplegia, and a respiratory arrest. In the hypothesis of Guillain-Barré syndrome, she underwent twice a lumbar puncture. She survived, and we operated her in emergency. Hopefully, she recovered after surgery. And other patients, they survive without explication. This is a patient who had two lumbar puncture. His Chiari malformation was discovered after the lumbar puncture, and he came out unscathed. Then the most common clinical manifestation of Chiari in children is chronic headache. Typically, the headache is posterior, brief, impulsive, caused by straining, and causing constipation because the patient is unable to strain. And headache is very often atypical in children who have to make the differential diagnosis with a migraine, with painkiller abuse, tension headache, refractive headache. And very often a small child presents with a torticollis, which is in fact caused by the pain caused by the tonsillar herniation. And even in very small children, this is a baby 8 months old. You see, he's trying to, you have to take my word for it, he's trying to look left and right, but he is unable to turn his head, only with a big effort. And this is after surgery. He was a happy child, looking right and left with much freedom, and he was very much improved after surgery. So we have to wonder how indicative of Chiari are these headache. The International Headache Society states that the evidence comes when the headache has developed in temporal relation to Chiari malformation and led to discovery. But we know that many so-called Chiari malformation are found because of MRI done for other types of headache. Then it resolved after surgery, so it does not help for surgical decision, obviously. And it is said to be not better accounted for by another diagnosis of headache. So is it really helpful? In fact, it is a kind of a new case of a snake biting its tail. So sleep apneas, it is typically a central sleep apnea syndrome. That means it is silent, unlike the obstructive sleep apneas, and it is significant when we can count more than 6 events during sleep with oxygen desaturation. This is an example in a small baby. You see him breathing, and then it stops. For how long? Then we have to make a decision we have to shake him a little bit because it can be harmful. And so the differential diagnosis must be made with obstructive headache, which can be mixed. That means obstructive headache can mask central apneas. Obstructive apneas, I mean. And you can have both causes in the same patient. This one has a Chiari, but also obstruction of the cavium because of palatine tonsils. And the telltale symptoms are that the patient sweats during sleep because of hypercarbia. It can be the cause of asthenia, of school difficulties. So, in fact, it can make the Chiari can be an explanation to school difficulties due to sleep apneas. But also you can have sleep disturbances without sleep apneas because the pain due to tonsillar herniation can occur at night and can lead to sleep deprivation. Cerebellar ataxia, in fact, is rare in Chiari malformation. This patient has a typical cerebellar ataxia, but in fact, he has cerebral palsy because he had a fetal distress during birth. He was born by emergency C-section. He had a motor delay and mild sleep apnea syndrome. In fact, his Chiari was not that impressive, and I chose to observe him, and I didn't have to operate him. Then you can have symptoms of syringomyelia, syringobulbia. It can cause pain in the limbs, in the spine. It can cause neurological deficit, typically with a suspended syndrome, and with amyotrophy, with painless wounds, like in this a teenager who was severely burnt without any pain, and trophicity problems in the hands, in the joints, and also structural scoliosis and cranial nerve deficits, like seen before, with this typical amyotrophia of the tongue. Then you can have other signs. You can have oculomotor disturbances. You can see a very fast nystagmus in different directions. You can have also this young girl. She had a nystagmus only when she was concealing one eye, and you can also have digestive symptoms. I already mentioned the constipation due to nucalgia during straining, but also you can have severe denutrition, gastroparesis, or interest in esophageal dysfunction, like in this case, and it can lead to stagnation of the weight progression. And another very common circumstance of diagnosis is the MRI done because of stunted growth. You see on this hypophysis MRI, there is tonsillar herniation. The MRI was caused because of stagnation of growth. So is it a chance finding? Is there a link between the stent growth and the tonsillar herniation? Because it can be a skeletal dysplasia. It can be a problem of content and container disharmony. And if you go to the internet, you make a search with a Chiari malformation and stunted growth. Here I found 54 results. That means it is a common occurrence, very well known in the literature. You have also cases of tonsillar herniation found during examination for craniosynostosis. It is common in multisuture synostotic, in syndromic. Here in this little boy with a pseudo hypoparathyroidism, with a pseudo Cruzon syndrome. In fact, he had a severe tonsillar herniation, which requires surgery. And sometimes it can also happen in monosuture synostosis, like in this case of sagittal synostosis, who developed tonsillar herniation within the second year of life. And also it can be found later. This is another example with a unicoronal synostosis with tonsillar herniation with central sleep apnea syndrome. And also it can be found later in life in older children or teenager with a pseudotumor syndrome, with intracranial hypertension with tonsillar herniation. So Chiari can also be found in a large number of different genetic syndromes. This is a small sample in my personal collection. It can be a genetic problem, a chromosomal disorder. So Chiari can be found in many, many different diseases. It is a common outcome of different causes. So it can be, in most of these, it does not require surgery. It is a chance finding during the exploration for all these diseases. Sometimes we have a chance of finding Chiari developing after obstetrical trauma in the follow-up of this patient. It has been well known for many decades now that there is an association between birth trauma and tonsillar herniation, but there are very few documented cases like in this one. You see the bump at birth due to vacuum extractor. And you see the Chiari developing a few years later with a syringomyelia. So in a previous study, I found that birth difficulties were found in 35% of the Chiari diagnosed at the time of the Chiari. So it's very significant. Also, it can be a type of Chiari 0 with arachnoid fibrosis and probably a disturbance of the craniocervical growth. Incidental diagnosis is a common finding, as I said in onset. It is an example of the victims of modern imaging technologies. This is an acronym coined by our good friend Thompson, who became president of the ESPN 2 years ago. At the same time as his kingdom had a new king crowned, at the same time he became president of the ESPN. So we have to wonder why these children had an MRI. What was the indication? It could be developmental delay, but there can be a link because it can result from dystocic birth. It can be school difficulties, which, as I said, can be the result of a sleep apneas. It can be atypical headache, but we have to ponder if it is neuralgia or migraine or tension headache or any other cause of a headache. And it can be dizziness. And dizziness, we have to remember that it is the number one indication for MRI in private practice in MRI in radiology, and that vertigo is generally absent in Chiari. So it is really a red herring. So what is the outcome of these asymptomatic patients? In many cases, it can regress spontaneously, like in this 9-year-old girl. We abstained and she improved very much thanks to our abstention. On the opposite, some rare cases can aggravate spontaneously. This was a child diagnosed at 12 years. She was asymptomatic and we decided to observe, but secondarily, she aggravated a few years later and she required surgery with very tonsil, as you can see. And also in this patient, it was a chance finding after a trauma, but the control after 1 year showed syringomyelia appearing and requiring craniocervical decompression. So in conclusion, the Chiari malformation has a very motley clinical presentation. It can be from incidental to chronic to sudden death presentation. So we have to remind that MRI shows just an image, and an image is not a disease. It is a still snapshot of a dynamic process. So we have to understand what this image means. We have to treat the cause and not the effect. So it is a question of clinical judgment, like the judgment of Solomon. I thank you for your attention.